Welcome to the SJMC Grand Rounds, where our experts come together and discuss challenging cases. Witness a synergy of intellect and medical expertise as we embark on our continuing medical education journey together. Before we start, I would like to remind you to subscribe to our channel and enable notifications so as not to miss our upcoming episodes. Now let's begin.
Good evening, everybody, and welcome to another SJMC Grand Rounds. Today is the 35th Cardiology Grand Rounds. 4 years in the making, and I think I must congratulate my cardiology colleagues for maintaining the course. Tremendous stamina. Anyway, let's introduce my colleagues. Chairing the meeting is Dr. Jayamala. Hi, Dr. Jayamala, and Dr. Koh. Dr. Koh.
Hello.
And we have our guest neurologist here, Dr. Yong Fee Man. Hi, Dr. Yong. Okay, that's great. So let's start off with some housekeeping slides. So this is the topic for today. So don't stay right to the end. It's very exciting because we have neurology and cardiology cases intertwined. And the interesting title, Brainstorms and Heartbeats. So we've got a few very, very interesting cases to share. For the Q&A, which is at the end of the session, please join us at slido.com. Event code is 2757466. If you scan the QR code with your phone camera, it will take you to Slido at this event code. Please do subscribe so that you will be notified of our upcoming live stream. Okay, so let's go back to Dr. Jaya, and I think I will let Dr. Jaya take over. Hang on a second. Mouse is a little unresponsive.
Thank you very much, Dr. Alan Tay.
Hang on, your share screen went off.
Right, so
Share the full screen one, yeah.
All right, so we go back to share screen. Share screen, and Windows, and we are here.
Yeah, hang on. Okay, right.
All right, can see.
I think you need to be on the full screen one. Let me give you a hand.
Okay, so just a minute, a few teething problems.
There's two. Which one is your 4-point big full screen?
It's not in
I think you put it in present mode. Then go back there. Then we go to the one. Which one?
this one.
This one.
All right, now we got everything in order.
Hang on. I will add.
Hopefully our webmaster allows us to go. We are raring to go.
We are ready. We are ready. Sorry for the slight delay.
Thank you very much, Helen.
Yeah.
Okay, so today we are having 3 very interesting cases of neurology and cardiology cases intertwined. The first case will be presented by Dr. Koh. Dr. Koh, over to you.
Yep, thank you, Dr. Jayamala. So I got this interesting case. It seemed to be quite simple at first glance, but then it turned out to be a bit more complicated than expected. So I have this 64-year-old lady who has history of dyslipidemia, not on medication. She was in the ward for a left distal radius plate removal. She was in the ward for dressing and wound inspection. So post-op day 4, she suddenly developed sudden vertigo and vomiting while in the toilet. The symptom was relieved actually after a few minutes, and the medical officer, inpatient medical officer, attended her, and she was already got better. However, the patient is a bit worried as he has a family history, that her elder brother has stroke before. So he was wondering whether does he need to be referred to a neurologist. Clinically, blood pressure is fine, pulse rate is regular, 70 beats per minute. Cranial nerve is intact, muscle power is 505, normal sensation, no ataxia, no cerebellar sign, good saturation. Further history, she actually is quite fit. She walks and jogs daily, non-smoker.
So, Dr. Koh, from what you have told us so far, what goes through your mind just based on your clinical examination and history so far?
Yeah, I think the most common thing I'll think of, the first thing that comes to my mind would be something very common like benign paroxysmal positional vertigo. It's a vertigo, basically. Differential, then I will probably look at the medication, because sometimes opioid-based medication, tramadol, painkiller, sometimes can cause the kind of giddiness, vertigo. And of course, rarely we encounter something like a stroke, especially at the cerebral stroke, which the neurological examination should have shown some abnormal finding, but on this patient, there's no documented neurological deficit.
Pulmonary embolism a bit unlikely, I guess, because of good oxygen saturation.
Yep, and the patient does not have shortness of breath or chest pain.
Okay. So,
So I look back at the previous ECG, the pre-op ECG before. The current heart rate in the ward is about 60 to 70, but the pre-op seems to be very low, about 40 beats per minute. It's a sinus bradycardia, no other ST abnormalities, no LVH changes. So nothing to worry apart from the sinus brady. But she's claimed to be asymptomatic. The next slide.
so now, is there anything else that you would want to consider, or just let it be?
Since the patient asked, don't worry about neuro, I'll probably refer to neurologist for further assessment, because the third differential that I always worry about, it's very difficult to differentiate as central vertigo versus a peripheral kind of vertigo. So maybe I have to ask Dr. Yong.
Okay, so these symptoms are very common, Dr. Yong. When would you actually think it's necessary to investigate doing a neuroimaging study? I mean, vertigo, like Ko pointed out, how do we know it's central versus peripheral?
Well, that's a very good question. The patient is unusual in the sense that she didn't have the history. It's the usual paroxysmal vertigo is when you are lying in bed and you get up suddenly or you turn your head. That history is not there. This one is she's passing motion, so she might be straining a bit, and then she suddenly had vertigo and vomiting. So maybe that would be a hint to me to say that this maybe is not the usual paroxysmal positional vertigo. And in case of doubt, always do.
Sorry, Dr. Yong, the sound went off. Suddenly there's no sound.
Has no
Yeah,
cerebellar signs after the event of vertigo and vomiting.
The interesting thing about a history is that if you consider benign positional vertigo, it usually presents when they stand up or turn the body suddenly. Now, this lady was in the toilet straining at her stool, presumably, and then suddenly she had vertigo and vomiting. That may be would be a red flag for me that we have to consider neuroimaging.
A CT or an MRI?
CT is.
Hold on a second. I think the thing went offline. This thing turn off. Don't know why the thing cut. Sorry, folks. The audio went off just now. Give me a sec. Don't know why it turned off. One second. Yeah, 1 second. Let me see whether I can get back the anchor. I think the anchor is better here. Right. Our conference mic. Some of us are in the conference room, so I think the problem is the conference microphone right now. So maybe we'll take back to what you said. Go back to what you said just now.
Talking about this patient who had her vertigo when she was sitting down trying to pass motion in the toilet, and she suddenly had vertigo and vomiting. In the case of benign positional vertigo, it usually presents when they turn their body. There's a sudden change in position, and then they get the vertigo. This lady is slightly different in the sense that when she strained, then the vertigo came on. Perhaps that is an indication to us that this is not a pure, simple, benign positional vertigo. And I would consider for neuroimaging, please do an MRI brain, because CT is quite hopeless sometimes for a lot of things, especially acute stroke.
Okay, so this is the scan done. Ko, you want to?
So this is part of the slice.
So there you see the white area there. It's a small lacoon, acute lacoon in the area of the posterior inferior cerebral arteries. So small stroke there. Next. And then you hit a larger area near the middle. Now this might be a different vessel, probably the anterior inferior cerebral artery. So two separate strokes on the same side of the cerebellum.
Yeah. Okay, so head and neck CT angiogram, cerebral angiogram was done. So why not an MRI? Yeah?
I think this depends on the doctor. Some MRA is quick, but sometimes you have to wait for it. CT angio has better resolution. If you're looking for things like aneurysm and all, CT angio is clearer. And also for acute stroke, sometimes we need a CT angio. This is both vertebral arteries flowing into the basilar. So you know that the right vertebral is very narrow. Very often this is a normal variant, that one vertebral artery is larger than the other. The left is dominant, as you can see. The right may be just hypoplastic, or it may be narrowed from atherosclerosis. But the pica comes off just the vertebral near the basilar. The anterior inferior cerebellar, now that's where the superior cerebellar is. And down there is the anterior inferior cerebellar. Yeah. So the arteries are quite far apart from each other. So looking at the two separate cerebellar infarcts on the same side, perhaps there's an embolus, because there are two arteries involved.
Okay. So would you do a thrombophilia screening, and why? And would you consider further cardiac evaluation?
This is part of the normal investigations of anybody with a stroke, especially a youngish person. The thrombophilia screen is important, because sometimes you pick up things like a positive angiocardiolepin, lupus anticoagulant. Yeah. And cardiac evaluation is also important in case it's an embolic event and you want to know whether there's any paroxysmal atrophy.
So I was called in. I was called in for assessment, and she's quite fit, and she get palpitation when anxious. Now, this is a very subtle history. A lot of people tell me that every time I'm anxious, I get palpitation. But retrospectively, a lot of times is they actually get the palpitation first, then only they get anxious. Usually it's like that. No giddiness, good effort tolerance. In the ward, the pulse rate is ranging between 60 to 70. Don't know why that the pre-op ECG is a bit bready. So this sometimes it going to I'm going to think of something maybe related to arrhythmia. For example, cases like sick sinus syndrome sometimes can present with a occasional sinus brady, and then you know that it is related to paroxysmal atrial arrhythmia, like atrial fibrillation or flutter. So this is something is like a red flag here. Thyroid function is normal, so it's not related to hypothyroid causing the bradycardia. HbA1c, as you can see, is pre-diabetic level, so that's already elevate the cardiovascular risk. Total cholesterol is on the high side. LDL cholesterol 3.3, total cholesterol 6. So the first thing for cardiac evaluation, I will definitely do echocardiogram. Many things to look for, but the main thing, most of the time, to be honest, is a negative finding. But what we specifically look for is either there's a presence of intracardiac clots. Dr. Jared already pointed there's a clot in the LV. This is usually a place to look for the clots, especially someone has infarct at the apical area, and commonly form there. Atrial, sometimes you can see a clot. I didn't show here. Sometimes you have to look for the second echo is an example of mitral stenosis. And sometimes in a severe mitral stenosis, you have a dilated LA, you can have clots forming in the LA. Cardiac tumor, very rare. I didn't show here. PFO, and how do you do a PFO? This is another example of a different patient, not this patient. Just want to show you. When we give like agitated saline, we call it a bubble contrast study. We infuse through the vein. What happens is you see the right side of the heart, it is filled up with the bubble contrast. Now, if you have a small patent foramen overlay and you ask the patient to strain a Valsalva, then you can see that a tiny, tiny bubble will go through the foramen overlay and goes to the left side immediately. You can see that the tiny, tiny bubble flow through. So this suggests the presence of patent foramen overlay. And sometimes you can see the atrial septal is being aneurysmal. Aneurysmal septum, not shown here, sometimes can be a source of emboli.
This bubble study that you talked about, what are you trying to look for?
Yeah. So especially for patients with highly suspicious of embolic stroke, for example, in this case, two separate arterial territory of infarct, then definitely I will look hard for this presence of the right to left shunt due to patent foramen overlay. It is a well-known risk factor for stroke. It is provide a conduit for the venous clot to travel from the right side of the heart to the left side of the heart. Then if you think back of our history, patients having straining in the toilet and suddenly have this kind of symptom, that's why it goes through my mind. Maybe I should check. Even though it's 67 years old, I need to check whether there's a presence of patent foramen overlay. Now, if the conventional echo, the color flow, sometimes you can see if the atrial septal defect is big enough, but most of the time it's very small. You can't see. And of course, we will do echo. Next will be a Holter. Nowadays, I tend to do a longer Holter so that we can pick up the presence of atrial fibrillation. And you can see that a 7 days Holter, one of the day, able to pick up paroxysmal kind of atrial tachycardia, very short lasting. And the definition of atrial fibrillation is, in the Holter, you need to have a 30-second evidence of atrial fibrillation. So then later on, you can see that the AF was continuous, regular rhythm, no obvious P wave, and then at the end, it resumed back to sinus rhythm, a bit bradycardia. So this confirmed the presence of atrial fibrillation in this patient. So the diagnosis, this patient has an acute right cerebellar infarction, and the paroxysmal atrial fibrillation, the thromboembolic rate straight away will go to 3. And how do we determine a thromboembolic the risk in a patient with atrial fibrillation? You have this Chapvest score. C stands for heart failure. If you have heart failure, then the Chapvest is 1. If someone has hypertension, you add on another 1. Age more than 75 is 2 points. Diabetes, 1 point. Now, if you have stroke, like in this patient, automatically it will be 2 points. And vascular disease, age 65 and female automatically got 1. So this lady is 64, I think 64, 63, 64, female. So 1 point there, and stroke 2 points. Total 3 points means that it's high risk for recurrent event of stroke. So she needs to be anticoagulated with oral anticoagulation. And she also had underlying dyslipidemia in this patient. So we started a medication, the direct oral anticoagulation. After counseling, always warn about the risk of bleeding. Basically, in general, major bleeding risk is probably about 1 to 2% per year. And the protection of stroke, if you are not anticoagulation, you can see that the stroke is ranging between 3% to 5% per year, so it's quite high. Statin therapy. Oh yeah, you are showing the risk. Go back to the risk score again. I just want to show others. These are annual risks. For example, you have a 3, so your annual risk of getting embolic event is about 3.2. Let's say if this month you see about 100 patients with AF, probably next year 3 of them will have a stroke. In 10 years time, there will be almost 30 of them will have stroke. So it's an accumulative risk quite high. Okay, and then statin. So patient actually previously is not been treated. It's not that not been treated. She actually followed up with a GP, but she reluctantly take the statin due to many myths. She was previously on rosuvastatin. So now for secondary prevention, I recommend high intensity statin therapy with the aim to lower down the LDL to 1.4 mmol per liter. And I will review the AF symptoms on and off because the patient subtly have palpitation. So symptom-wise, not too bad. And I couldn't start medication because there's an evidence of sinus bradycardia. So it's a bit difficult for medical therapy for this lady. Is there a role for smartwatch nowadays? Possible. So if she wanted to have new birthday gift, probably I think you can buy a smartwatch. So like Apple, Samsung, which have capability to actually detect the presence of irregular heartbeat. They have some programming to detect that, and their sensitivity especially are actually quite impressive, I would say.
So if they had frequent AF or is symptomatic, what would you do? What would you advise?
So in this case, I can still try on and off, we call it a pill in a pocket kind of medication, like flecainide. Flecainide is a pill in a pocket medication to tackle paroxysmal symptoms of atrial fibrillation. A relatively short onset, so if you take 1 dose, then you expect the heart rate to go down within the next 6 to 12 hours. So not too bad. We can try if she having increase of atrial fibrillation detected in the watch, which coincide with her symptoms. If there's no symptoms, perhaps I wouldn't treat the AF per se, unless the burden is getting higher and higher. And how do you know the burden? Now, again, specific smartwatch. I'm not going to. There one brand I know, but I'm not going to name the brand. They they can actually roughly gauge the burden of atrial fibrillation if you are wearing the watch. For example, if you wear a watch for 24 hours today, if your heart rate goes irregular, for a certain period of time, they can roughly tells you there's 4% AF burden, 10% AF burden. So that's roughly give me an idea. If the burden is getting higher, we know that at such a relatively young age, the atrial fibrillation is probably going to get worse and worse, and you will get the sinus node to be more sick, and this patient may have to implant pacemaker earlier on. Then the discussion about definitive treatment for atrial fibrillation, which is atrial fibrillation ablation, comes out after this.
Okay, so moving on. Yes, you have answered the first question. What about Young? I'd like to ask you, a lot of neurologists are worried about very low levels of LDL. What are your views on this?
Well, all the studies have shown that, the latest ones anyway, that they are compiled. There is really no evidence that very low LDL causes an increase in the cerebral bleeds, dementia, what's the other one that's often depression also. So the brain consists of 25% of cholesterol, but I think there's a blood-brain barrier where the systemic cholesterol doesn't enter into the brain. So the circulations are different, and I think the systemic LDL involving affecting the vessels do not really correlate with any problems we have with the cholesterol in the brain. So what I'm trying to say is, there's no evidence really that very low LDL will cause problems in your brain with regards to increased bleeds or depression or dementia.
Great. Thank you very much, Dr. Young, because everybody tells us that after taking the statin, their brains are going. So they are dreaming, I guess. So the last questions are, this symptom is very, very common. What indicators would you like to tell the GPs, hey, this patient should be investigated further?
Most of cerebellar infarcts that present with vertigo, they have other things involved. They will have dysarthria, then they cannot swallow, they have numbness, weakness, they have diplopia. Those are the simple ones. But in this case, so I have to be very careful. The lady didn't have anything. She just had vertigo, vomiting, and then apparently very well. So maybe the history. Have to take a very detailed history. Family history of stroke, and the fact that she wasn't turning when it suddenly happened. When in doubt, just investigate.
So the learning points, I guess, from this case is, if it is not a typical vertigo with some of the red flags that Dr. Young just mentioned, investigate. Is that correct, Dr. Young?
Yes, yes.
Okay, moving on to case 2, Dr. Young.
So anyway, I was on call that day, and I had a call from the emergency MO at about 7:12. Doctor, there's a 74-year-old male. He's transferred in from a hospital to another city, from another town, with right-sided weakness. They did a CT there, and the CT was normal. And they said, what time did the symptoms start? 4:30. So I was informed about 7:12. So I thought, 2 hours, 40 minutes. And so I sort of woke up from my slumber. Maybe I can thrombolyze this patient and reverse the stroke.
So what is your advice to laypersons that if someone comes in with sudden onset neurological symptoms?
Well, try not to sort of try to sleep it off. A lot of patients will say, I woke up with a bit of weakness, so I went back to sleep because hoping that when I wake up later, it'll be better. Or they go and see their GP because they need a GL, or they will go to the Chinese doctor to get some herbs and acupuncture. So when you do that, and it's a real acute stroke, there's a lot of time wasted. Time is of the essence. If the neurological symptoms are severe, please come to a hospital where we can do something for you, potentially. Then I took a history from the wife. There were a lot of people milling around. There were his wife and his children and all that. So her story is that at 4:30, he was walking around and suddenly had chest pain and collapsed. It was not rousable for at least 15 minutes. Then they went to this hospital. A CT scan was done, all normal. And because of the right-sided weakness and there's no neurologist there, they asked to transfer to Subang.
Can you explain the sudden LOC and unarousable for 10 to 15 minutes if the patient had a stroke?
In the context of a stroke, it is highly unusual for this presentation. You'll have to stop the arterial supply to both carotids and the basilar. Sometimes you have acute basilar artery obstruction. They will be quadriplegic and can't move, but they will still be conscious. So perhaps if you had a stroke and you had a seizure, maybe there's not arousable, but in the case of a seizure, you will see the person jerking. So in the context of a stroke, purely loss of consciousness and not rousable, it is highly unusual. So when I examined him, he was restless. Intermittently, his eyes was deviating to the left. There was obvious right-sided weakness. And when I examined him, the plantar was upgoing. He wasn't responsive. Now, this combination of eyes deviating to the left, right-sided weakness with the right upgoing plantar and patient restless and non-responsive, I would think of an acute left middle cerebral or even a left internal carotid artery obstruction. But then the next minute, he would sit up and started to make some noise, non-comprehensible sounds, and also said, "I'm thirsty." And he was moving all four limbs. He could sit up and wave his arms and legs around. So that was very strange. Then I noticed the blood pressure was low, 98/60. His heart sounds were normal. And then I noticed he had bruising in both forearms, including the side of the cannula. Now, this is not the patient's arm, but it's just to say that he had discrete, very fresh bruising. So when I asked the daughter about the bruising, she said, "Oh, my father is always like that. He's always had this bruising." Oh. So I have to go and ask a detailed history, because why did he have bruising? He wasn't taking any Chinese medications. He wasn't on steroids. He wasn't on blood thinners. He only had high cholesterol. And he came with a whole lot of family, so I had to tell who is who. So he came with his second wife and 3 sons and 1 daughter from the first wife. And he had retired, he didn't smoke, and he didn't drink, and apparently was in good health before.
So can you explain the sudden changes in conscious levels and neurological signs? And is there any unusual red flags that you think from your clinical examination so far?
So yeah, there were lots of red flags. Looking back now, I thought I should have made the diagnosis there and then, but I wasn't thinking. So I know I was confused, but I didn't know what the diagnosis was.
So you want to tell us some of your red flags?
Yeah, here are the red flags. This guy presented with chest pain. And then I found his blood pressure is lowish. In the case of acute stroke, the blood pressure goes high because they try to keep the artery patent. So why was the blood pressure low? His hemoglobin had come back by then. It was not low. He had no abdominal pain, no evidence of bleeding. And his signs were alternating between an acute MCA, ICA infarct. And then suddenly he would sit up, he'd be restless, he's moving all 4 limbs, but he couldn't speak. And then he had bruising in the forearms with no history of blood thinners or steroids.
Before that, how do you manage acute strokes generally?
Okay, if he came in with just purely a right-sided weakness, he could still verbalize, and I thought it was a left MCA infarct. And within the 4.5 hours limit, I would thrombolize him. If there's no history of bleeding or or whatever else, I would thrombolyze him acutely.
So here there was some red flags, right?
So what I thought, maybe this is an unstable middle cerebral artery or internal carotid artery occlusion. So because maybe the clot would sort of go off and then form again. So if it's unstable, maybe I should thrombolyze him and lyse the clot fully. So if the CT scan is normal or the aspect score is good, then I would thrombolyze. And in my practice, after giving 10% of the actylyze, then I would finish the infusion while I did the MRA. So the medicine was already open, diluted, and waiting to be used.
What is this aspect score that you talked about?
So the aspect score is what we use based on the CT brain, where we divide the brain into 10 segments. So at the level of the basal ganglia, the brain is divided M1, M2, M3, and then the basal ganglia, caudate nucleus, lentiform nucleus, insular. I think it's quite hard to point. And then the internal carotid. Anyway, there are 10 of them. What happens is that there has to be a gray-white differentiation. If you cannot see a gray-white differentiation, then you take 1 mark off. So anything above 8, the thrombolysis the chance of a good outcome is very good. Less than 7, then it is not so good. So the aspect score is what we use in places where they don't have a qMRI or a CT perfusion. We can just use a basic CT brain to see whether you can thrombolyze and get a good outcome. But then because of all the red flags, I wasn't sure what I wanted to do. I decided to do CT perfusion and CT angiogram first, in the sense also to buy time. And then I was very lucky that day because the radiologist was around and he could give me an instant report. And there we have, there's a dissecting aneurysm. This one also.
Play. All right, as we play.
Okay, is there no sound? Is the sound all right?
You see the lungs are really grotty as well. I don't know why. And there's the aneurysm.
The dissection.
Yeah, dissecting aneurysm. Can I just go back to the CTA? Maybe I can show.
I have to say the pictures are beautiful.
Right.
The images are beautiful. CTA.
Yeah, you can see the dissection here, and then this wormy line is going up the left internal carotid, and even it goes across, even the right one is also involved. So this very fierce aneurysm was going up into all the arteries in the arch. So we've seen that. Yeah, that's the same thing. So I had to look up dissecting aneurysms, the type A and type B. His was the type A, type 1. I think the worst of the lot. So it went from perhaps somewhere in the abdomen and went up and went right across and then went into the cardiac cavity, I think. So diagnosis was ascending aortic dissection involving the carotids. So I was in a state of panic. I called the anesthetist. I called the vascular surgeon. I was very fortunate that day because within 5 minutes of calling everyone, they came. And this was at 8 o'clock p.m., on some, I don't know which day it was. So the anesthetist intubated the patient. Gave fluids. We had to stabilize the patient. Theoretically, we should send him to a hospital where they can deal with it surgically because nobody else can deal with this. but we really didn't have time. But we were seen to be doing everything. The vascular surgeon explained to the family, and we were doing our best to resuscitate him. And meanwhile, I noticed that his forearms, the bruising had become confluent. So from discrete bruises, the whole arm was purple. And then I noticed his lower limbs were going mottled, including the neck. Whereas an hour before, the pedal pulses were strong. And then code blue at 10 p.m., CPR for 30 minutes. Although they couldn't have saved him, they did it because the family was around. And he died at about 10:30. So I want to go through all the causes of sudden severe chest pain. They are divided into cardiac, gastro, respiratory, infective, and sort of other causes. So amongst all the things, cardiac, heart attack, coronary artery disease, pericarditis, aortic dissection is one of them. Then there's a lot of gastro causes, ulcers, esophageal spasm, GERD, hiatus hernia, and then the pulmonary embolus, COAD, pneumonia, pleurisy, pneumothorax, pulmonary hypertension, fractured rib, sprained chest muscle, which is very common, costochondritis, shingles, CA lung, and also not to forget panic attacks. So all of this causes of sudden severe chest pain, none of it says acute stroke. So the learning points for this case is history is very important. So if you are the first doctor the patient goes to, or the family rings you up and says, doctor, there's right-sided weakness. But if he said he had chest pain and he collapsed first, it's never just a stroke. So now retrospectively, I knew it could only be dissecting aneurysm. So
do not send the neurologist. All right. Okay, the third case, we have to thank Dr. Ng Cheng Huat, who is MRCP physician GP in Klang, for sharing us this case. Dr. Ellen Tay will be presenting.
Thank you very much, Dr. Jamala. So all credit to Dr. Ng Cheng Huat. He actually presented this case in the DOPS forum as a teaching and sharing experience. It was fascinating because it's something we hardly see these days. So the patient came to him. He was a 23-year-old Myanmar foreign worker. He has been living in Malaysia, working in a factory job for 2 months. And he presented to Dr. Ng with rapid heartbeat, shortness of breath, and swelling of his feet, which lasted about 4 days prior to seeing him.
So, if you were a GP and you saw this young man presenting with symptoms and signs of heart failure, what would go through your mind as your common causes?
I think the common causes for young men with heart failure is usually dilated cardiomyopathy, usually those kind of genetic or inherited, or idiopathic dilated cardiomyopathy. That is probably one of the commonest one. Then followed by probably ischemic cardiomyopathy, although it's still young, but now we see a lot of young patients with ischemic heart disease. I would say the next in line would be myocarditis and valvular heart disease. Not so common, but we still see on and off. Then the rest would be probably a bit more rare, like arrhythmia-induced cardiomyopathy or thyroid cardiomyopathy. Then the bottom differential, of course, a lot of differential for young patients, even more rarely seen, infiltrative cardiomyopathy. If this is a foreigner, then I'll probably think of like constrictive cardiomyopathy, especially TB. TB can cause a constrictive cardiomyopathy. And of course, rarely I would think of things like nutritional deficiency causing cardiomyopathy.
So further findings on examination. He had mild tachycardia, BP on a bit on the low side, and clinically, Dr. Ng Cheng Huat diagnosed the patient was in congestive heart failure. He performed a thyroid function test, which excluded thyrotoxicosis. So in the GP setting, he straight away instituted anti-failure medication.
So, Ko, your patient, no money, no insurance to see specialists. How would you have managed his heart failure in this patient as a GP?
Actually, the treatment for heart failure is very cheap. Only. Number one, I will alleviate the symptom of heart failure, of course, by the means of using mainly diuretics. Simple diuretics like furosemide is very cheap, very effective. Of course, aim number two is to try to introduce a medication to improve heart failure. And these medications are widely available and very affordable. For example, like ACE inhibitor, our good old enalapril, ramipril, nowadays generics all over. The use of beta blocker like bisoprolol, and also the use of the spironolactone. These three medications, perhaps we can initiate early in the GP setting.
So now, 3 days later, the patient came again and said there was numbness in the left lower leg. And in that area, he was noticed to have diminished sensation to touch. And there was severe weakness in dorsiflexion of both feet. He was unable to dorsiflex both big toes, and he actually demonstrated some difficulty in walking. The muscle strength was normal in the other muscle groups and movements, and there were absent reflexes noted in the biceps, supinatus, knees, and ankles. So the diagnosis made by Dr. Ng was peripheral neuropathy. So let's ponder now. We've got a patient, young man, foreign worker, who presents with heart failure of recent onset, and then followed by peripheral neuropathy. So what could be the differential diagnosis?
Okay, so Dr. Ko, you want to start first, and then I get Dr. Yong.
The most common cause is probably uncontrolled or poorly controlled diabetes mellitus. These are probably the more common one that I've seen before.
Okay, what about you, Yong?
Well, if the sequence event was weak peripheral neuropathy first, followed by heart failure, then I would consider something like demyelinating disease like Guillain-Barré. It'd be quite acute, and then the myopathy, reactive myopathy. That's the only thing I could think of, actually, in this patient. But if I sort of read it up, then there's a lot more differentials.
The rest of the differential is very rare. Yeah.
Yeah. Well, no, I mean, if the patient had malignancy and was on chemotherapy, then the reason to be obvious is due to chemotherapy. If the patient was older, you want to consider amyloid or some sort of autoimmune thing. But autoimmune peripheral neuropathy, like vasculitis, it's very painful. They won't present so in the clinic. They'll be so very hard. In this case, without reading up, I really didn't know what it was.
So
alcohol?
Alcohol, yeah, but the history will be so obvious, There'll be alcoholic.
I came across one interesting social media post which is going wild. It's going like viral. It's called the Rashomon effect in healthcare. Have you come across it? So Rashomon is actually a Japanese movie where the video was taken from different angles, so the interpretation is different. So if a hematologist sees this peripheral neuropathy and heart failure, I would say amyloidosis. If a rheumatologist would say, oh, it's some form of autoimmune disease, collagen disease, or vasculitis. Neurologists would say Guillain-Barré. Diabetes, endocrinologists would think of, but I think each of them have its pros and cons. For example, diabetes, you really need fairly long-standing disease before you get these complications. So let's perhaps move on. Next slide. So the answer is take more history. So Dr. Ng Cheng Huat took more history, and it was a starting revelation that this patient had been only subsisting on plain rice and water for 2 months while he's working in Malaysia. And maybe some of them are trying to save money to send money back home, So actually quite destitute condition, and various social, economic, environment factors, all these contribute to this very poor diet. So what do you think it might be now?
So was the eggs the only source of protein?
This is a automatic picture generated by the PowerPoint code generator from ChatGPT. But anyway, yeah. So it's actually what coincidental ends.
So we have something with heart failure, peripheral neuropathy, with some nutritional, giving some hints that maybe it's something nutritional. Dr. Yong, do you think of any nutritional causes?
Suppose B1 deficiency, having known the answer, very, very.
Yeah, so the final diagnosis is actually something I think literally unheard of these days. I mean, maybe in the days of
not because we don't treat this sort of cases, but if you ask the doctors who worked in all these refugee camps, they probably see them every day,
Yeah. So it's amazing. I think later on the GPs in your comments and sharing, maybe you tell us if you've ever seen a very, I've personally never seen one. I only heard of it maybe in the days of the wartime Japanese internment and all that.
I'm sure it exists now, but in a different demographic patient.
If they only eat white rice, they can't afford to come to SJMC.
Yes, precisely,
I don't think we'll be seeing patients here like that. But, okay, so I think ideally, if you're a bit academic, you want to confirm it, and the test is supposed to be called the red cell transcriptase activity, but that's all tests. In GP practice, you want to treat the patient. So I think what Dr. Ng did the right thing. Actually, just treat with B1 replacement, and he administered intravenous thiamine, and there was a marked improvement in the cardiac side. So there was all the heartbeat, the breathlessness, and the leg edema improved, and he did not need any more anti-failure treatment after about 3 weeks. Yeah. The numbness and strength were also improved as far as the leg, and then the power also recovered. And there was still a bit of persistent areflexor of the biceps and so on, but generally neurologically also improved.
So the learning point, I guess, will be you take a good history. Sometimes it's maybe some things which are very unusual. It may just be nutritional, and be careful of the Rushman effect. It's very important to be a good generalist first before you become a specialized and look at the patient through binoculars.
Well, I think the patient is very fortunate. He went to see a good generalist. So all kudos to Dr. Ng Cheng Huat. I mean, you need an astute, good general physician, look at the patient as a whole, take a good history, and treat accordingly. So actually, all kudos to Dr. Ng Cheng Huat. You come to SJMC and CNF, we'll be investigating high and low from the Rashomon effect due to our own various specialties and biases. Actually, this is where a good GP and a good generalist actually can do much better. Okay.
Thank you very much, Dr. Ng. And actually, I use a lot of thiamine in my heart failure patients because some of them are alcoholics, so thiamine might help. Thank you very much, and back to you, Dr. Allen.
Yeah, okay, let's go back to my slides. Give me a second. Okay, so if you got questions, you can ask in either YouTube or in Slido. There was one question in YouTube, I presume going to the first patient. What was the fundoscopy findings? First patient was...
First patient is Dr. Ko.
Yeah. Fundoscopy was not done for this patient.
Rashomon effect.
Maybe you should ask the ophthalmologist to come in. So what do you expect to find anything in the fundoscopy, Dr. Yong?
I don't think so. No, this is a pica. You might see some nystagmus. Sometimes when you're trying to look in the eye, it's sort of jerking, and then you notice nystagmus, which you can't see unless you go very close. But it's not in the occipital lobe, so I don't expect. Oh, sorry, that is visual field. So I don't expect anything unusual.
Did the patient have any visual effect?
I didn't see the patient. It's not my patient.
Oh, okay. Maybe they can get occipital blindness or something.
Well, that's
like that.
if you have occipital infarct.
Right.
Then you won't see in the endoscopy. You have to do visual fields.
Here, the infarct was not in the occipital lobes, not in the occipital lobe. Sorry,
this is a cerebellar infarct.
Okay. Right. Any other comments or questions? Maybe I asked about the second case. And you noticed there was bleeding. Was it actually bruising in the skin?
Acute bruising. So I think because of the pressure of the dissection, maybe the blood was rushing because both what do you call subclavians were affected. No, maybe it's just pressure onto the arms, like someone squeezing the blood out into the skin.
Yeah, because I'm aware also in dissection you also can get a consumption coagulopathies.
But nowhere else, you see.
Right.
Only the forearms. I mean the upper limbs.
It's just curious because I had a patient long time ago also had chronic like DIC kind of picture, but he had also aortic dissection, but not
this one didn't have time to develop any coagulopathy within 3 hours.
Yeah. I think this type of dissection is probably the worst type, and I think hardly anybody will be able to survive that.
No, but the fact that I'm very fortunate I didn't give thrombolysis because I would have caused him to die straight away instead of 3 hours later.
Lucky escape.
Learning point. Learning point.
Yes, very lucky for me.
Okay. No questions in Slido. All was done. If you have any good cases to share, please feel free to reach out to me in Dobbs and also share. I think sometimes we learn a lot from our GP colleagues. Okay, so I think we also reached 1 hour already, and we should really get on to the CPD points. Don't forget to subscribe, yeah. Okay. This is the attendance link. Thank you all for watching. For the doctors, you can go to dobbs.my in your browser, dobbs.my/030824. That's today's date in your browser. If you have your camera app in your phone or a QR scanner in your phone, this is not the MMA QR code scanner, just a normal phone scanner that will help you take you to that link. That will be a form for you to fill in your details. Then we will upload your CPD point for you in about a week. Okay, so you'll get 1 CPD point for watching. If you are watching non-live from tomorrow onwards, you will be able to claim your CPD point by making a comment in the video and sending us a request for scanning in your points. And please read the pinned comment in the YouTube video. Open the video in YouTube, look at the pinned comment, and you'll see clear instructions on how to claim the point in case you are watching this non-live from tomorrow onwards, and you'll be able to get points right up until 30th of June next year. Okay, so all our live events are like this. So we have 2 live events every month, and you'll be able to easily get your 20 points just even by following our webinars. Okay, so if the video will be there, you can always play it back and watch and look at the QR code and scan it, or go to dobbs.my/030824 in your browser, your laptop browser or iPad or phone browser. Okay, I had a request from paramedical staff, nurses, medical assistants. Also, they also actually need CPD points, so they're trying to help them. And so this one is not for the doctors, so please don't go and scan this. And listen carefully. If you're a doctor, do not use this form. This form is for nurses, pharmacists, medical assistants. If you're attending, you can go to dobbs.my/attend in your laptop, phone, or iPad browser. You also can scan this code in, as it will take you to that same link. So what happens in that link is just a form. You fill in your details, and then automatically you will get an attendance cert in PDF format sent to you with your name and your license number attached there. It's just a very plain PDF, no fancy graphics, but at least you have something so that you can submit to your association to claim points. Okay, right. So just one more reminder, we have taken the trouble to upload the SJMC Cardiology Symposium, which was held in January 2024. It's still there. You can watch it. A lot of good lectures there for you. It's a 5-part series. So go to dobbs.my/SJMC-CCS2024 or scan this code in your mobile phone, or and we'll take you to that playlist. So it's a 5-video playlist for you to go through all the lectures held this year in January 2024. Okay, there are no CPD points though. The event was only for those who attended, but still a lot of learning. So I think with this, I just want to thank all my colleagues, Dr. Jayamala, Dr. Yong Kim Man, and Dr. Ko, and thank you all for attending our session today. And we hope to see you in the next one. Okay, and we'll wish you a happy weekend, and take care. All right, we'll end the stream now. Bye bye.
Thank you very much, Alan. Thank you very much, everybody.
Thank you.
Thanks. ChatGPT.